the Hospital of the Future. My name is Dr. Vivian Reyes. I'm the Regional Medical Director of Hospital Operations for Kaiser Permanente in Northern California.
Hi, folks. My name is Balaji Venkat. I'm a practicing ED and palliative care physician, and for the past few years, I've been lucky enough to be working as a virtual hospitalist and helping lead Kaiser Permanente's advanced care at home as a regional medical director and physician lead.
I'm Chris Hasse. I serve as the chair of the Advanced Care at Home program and practice strategy for Mayo Clinic. I'm excited to be with everyone this afternoon.
And again, welcome. So we are going to be talking about hospital at home, the hospital of the future. And I'm just going to start by saying that I truly believe that these programs, the hospital at home programs, will transform the way that we deliver hospital level of care to our patients across the country and possibly across the world. The reason for that is that these hospital at home programs, they give us a window into our patients' lives, and it allows us as care providers to really understand what matters most to our patients. And what we're able to see as a healthcare team is something we have not been able to see in brick and mortar hospitals now. What we can see is we go into their home, we see what relationships they have with others. Are they healing relationships, or perhaps they detract from their health? We get to see what medicines they actually take, what food they eat. We can even see things in their home like, maybe there's wires and they're tripping over them, or maybe there are rugs in their house and that's what's causing them to fall so much. So it really gives us a unique view, and it gives sort of a unique power to our team to really treat our patients as whole people, as opposed to a patient with diabetes or a patient with congestive heart failure. And that is the beauty of hospital at home. So what I'd like to do is sort of talk to you about how we started our journey. Why did we decide to embark on this journey? Well, there were certain things that came together when we began our journey. And I think everybody knows that the volume of patients who require hospital level of care or acute care is growing. We also know that those patients are older, they are sicker, and they have more diverse care needs. We also know, especially after COVID, we know that hospitals can be capacity constrained, and our patient focus groups tell us that unfortunately, our hospitals are not that pleasant to stay in. The other thing that was happening at the time we embarked on this journey is that technology is everywhere. So on our cell phones, we can get food, we can order anything we want, we can connect with anyone or anything, and everything is on demand. And because of that, patients also want this on-demand service within their healthcare. And so that was also coming to us, and our patients were demanding this. And then lastly, we're always being asked to do more with less, without raising the cost of healthcare. So that all of these things, in addition to all of the kind of the literature that was coming around hospital at home programs at the time. So this is actually data that we got from our medically home partners, whom we'll talk about in a moment. But there is an existing body of literature that supports hospital at home programs. And I will tell you, first and foremost, patients absolutely love hospital at home programs, hands down, no question. If you look at HCAP scores in the programs that Medically Home runs across the country, the HCAP scores are much better than the brick and mortar. Also, their top box is also higher. And we see this time and time again. I don't think there is a single patient that does not prefer a hospital at home program to a brick and mortar. Also, the quality and safety of these hospital at home programs are also kind of impressive. So they saw a 66% reduction in readmission rate. We also are expecting to see reductions in our return to ED rates, as well as hospital-acquired infections, and also things like delirium, falls. And we also think that there's going to be improved physical function to our patients in these programs. And then lastly, there's a cost reduction. They saw a 30% reduction in the cost of care per day versus a brick and mortar patient care day, and also a 1.5% bed day savings. And so all of the factors I talked about on the last slide, in addition to everything that we were seeing with hospital at home, it was a no-brainer for us to move forward on this journey. So we went ahead and we partnered with a vendor called Medically Home, and together Mayo Clinic and Kaiser Permanente joined forces to create our programs. And so we both developed our hospital at home programs. Kaiser's program is called Advanced Care at Home. And together we are treating our patients and really meeting our patients where they are in their homes as a whole person together with Medically Home. And so now what I would like to do is I'd like to go through a patient story. And so I'm going to introduce you to Ben on this next slide. And so Ben is a 64-year-old. He was a retired firefighter. And he went ahead, he was going on his, he was going to go on like a family reunion. It's a mountain getaway. And he goes every year. It's a few days long. He has a history of diabetes. And when he was starting to get ready to go on this trip, he noticed he was having some urinary symptoms. And he developed some fevers. And he went to the emergency department where he was found to have a urinary tract infection. He also was sort of on the borderline of having some early sepsis, and the team felt that he needed to be admitted to the hospital. So he was evaluated and he was determined to be a candidate for our hospital at home program. So he was evaluated by our hospital at home hospitalist, and he passed a social stability screen, which is what we do for all our patients in the program. And it was determined that he would be an excellent candidate for our program. So we, of course, this is a voluntary program, so we asked him if he would be interested. And of course, he was elated to be in our program because, you know, like I said, patients find hospitals kind of unpleasant. So he agreed to be in our program. And so the way it works is an ambulance comes to the emergency department, picks him up, brings him home, and he has everything that you would have in a normal brick and mortar hospital. So he has daily visits with a remote hub team. And the remote hub team is comprised of a physician, which is a hospitalist in our program, a nurse, and a patient care coordinator. And so they together round on the patient every day. And then on patient day number 1 and 3, a physician assistant will come into the home. And there is a suite of technology that is in this home that allows this two-way communication between the hub team and the patient. And then there are people who come into the home like the physician assistant. So they come in, they examine the patient, and in conjunction with the hub team are able to deliver that care to the patient. Also, the patient gets daily labs. He also got every 12 hours, he got IV antibiotics that was needed. Because he was diabetic, he also was put on a glucose monitoring program, and he got insulin on a sliding scale as needed. And then he also was put on a diabetic diet, and then they monitored him. This patient did extraordinarily well. He improved over 3 days, and he had blood cultures that were negative, and that was great. At this time, the team felt that he was ready to be transferred to what's called the restorative phase of care. Now, this is something different, and I personally think this is the secret sauce of the program. And this restorative phase is not something that we have in a brick and mortar model. So in a brick and mortar model, what happens is you have a patient, they're admitted to the hospital, they're eating hospital food, they're laying in their bed, they're isolated from their family and friends, and then the next day they go home and they go back to their normal life. And it's kind of like a light switch, and it's pretty drastic. So in this model, we have restorative care phase, which is, it kind of takes that transition and then spreads it out. So this patient was transitioned from IV antibiotics, and he got the IV antibiotics, and then he was transitioned to oral. So we could be there and assist him if he was having any trouble with his side effects, and then he could figure out how to incorporate the antibiotic to his regular medicines. He also was taken off of the insulin sliding scale and put back on his normal diabetes medication. And so the other really important piece of the restorative phase is that it allows him to really get educated on both the acute illness that he has, as well as his chronic disease. This is a man who had had diabetes his entire life, and yet we were able to look at his refrigerator and tell him that some of the things he was eating was not necessarily conducive to his diabetic lifestyle. So even someone who has had education through their lives, we are able to affect them in a positive way because we have eyes into their home. So this patient did well in the restorative phase, and he was really itching to get back to that family retreat. So he left a little bit sooner than we would have liked him to, but we felt comfortable with that. And he actually was able to go and meet his family and continue on with the retreat. So at the end of the visit, what we do is we do a summary that gets sent to his primary care provider, and it lists out all of the things that happened during his visit. And then we, of course, let the primary care doctor know what follow-up items there might be. And the other thing is then we have to, of course, take all of the equipment out of the house. And Dr. Venkat's going to talk more about that in a moment. But I wanted to take a moment and I wanted to do a couple polls. So the first poll I'd like to take is to find out who is in our audience. So you all should see a poll come up, and if you could all just answer that, and we can see who you all are, and it'll give us an idea of the types of questions we'll get.
Thank you, and you should see the poll on your screen, and there's a submit button, and we'll give you a few moments more before we close the poll.
So it looks like so far we have a good mix. We have physicians, we have some administrators, executives, IT leaders, nursing leaders, and a big bucket of folks who are from other backgrounds. Small number of management supervisor positions. So I think this looks like a good spread. So thank you. And the next question I'd like to ask is I wanted to see where everyone is on their healthcare journey on hospital at home, knowing that we have, it sounds like we have a good swath of people in the audience. So if you can answer the question that's on the screen, so which option represents your company's status on hospital at home? And while we collect this, I'm going to pass it on to you, Dr. Venkat.
Thank you, Vivian. And folks, as you can tell from from Vivian's story, the patient's journey is the lens that we like to view our program. It makes a lot of impact to us when we see the patients, just so much gratification to see what they do. In order to pull off the type of intense care that we talked about, that Vivian just displayed, we have to take many steps in order to provide high quality care in a safe environment. We want to be effective and responsive to the patient. That's how we can make the journey amazing. One critical element, of course, is technology. So we use a suite of technology to bring it all together for the patient and the clinical team. So we're sharing here on the slide here some of the technological equipment that we use. The tablet, it's preloaded for video visits and schedule awareness. We even use this venue to get responses from patients to gauge their experience real time and make effects and changes when needed. We also see the phone that's there. Now that's a backup phone. I call it the bat phone because when it rings, the patient knows the hub is calling. And when the patient picks up, they don't have to dial a number. They don't have to think about any numbers, even dial. It automatically rings in our virtual hub. And this virtual hub allows the patient to feel comforted and safe. We want the communication with this hub to be seamless both ways. And the other equipment that you see on here, so pulse oximeter, the heart rate monitor, the blood pressure cuff, the scale, it's Bluetooth enabled. These all help us gauge. Each one of these items add value for us as a clinician. We have an episodic window into the patient's health. And this means that there's usually no surprises from our patients to us. We know what's happening before it happens often. And then of course, these biometrics are uploaded so our clinical team can trend them and make appropriate decisions. So I'll tell you, the pulse oximeter and the heart rate monitor, for instance, was extremely effective during our COVID pandemic this recently. Now, we had quite a few patients that were admitted in our program for COVID pneumonia, and we were able to provide IV remdesivir and medications at home. Now, that's great, but with this pulse oximeter and heart rate, we're able to educate the patient about oxygen utilization, steroid utilization. We even taught them about this particular therapy called self-proning. It's incredibly important because it helps with recovery from COVID pneumonia. What you do essentially is you're on your stomach for 15 minutes at a time, 3 times a day. Well, it makes a big difference when you tell a patient who's already short of breath to do this when an oxygen monitor and a heart rate monitor are on you, and your clinical physician and your clinical team is aware of what you're doing and are about to do it. We saw our patients improve because they did more therapy like this. The scale that you see, these are patients that are admitted for water retention and fluid retention. They need diuresis in their home environment. We don't have to guess what their weight is. If you ever ask a patient, what their weight is, it's what I would call ideal weight, not the actual weight. It's always funny because ideally this is my weight. Well, in this situation, we know what it is, and it's automatically uploaded for me to compare day to day or week to week and make decisions based on the diuresis. We see how much fluids are going in and out. The scale helps us differentiate our therapy within their home environment, something you can't do in the hospital, because at home, someone could be hoarding Gatorade that we didn't even know about. In the hospital setting, we wouldn't even realize that. Anyway, so that's some of the equipment that you see that the patients touch base with. So the other ones that you see here are wireless routers and backup battery packs. This is to make sure that no matter what happens, that we have multiple redundancies built in to make sure communication and patient safety is of utmost importance. There's even something that we call a personal emergency response system. This is equivalent to, I've fallen, help, I've fallen, I can't get up. So this is where if a patient is away from the tablet, they're away from the phone, they're not near normal communication, they have this device attached to their body, and they typically wear it. And essentially they automatically indicate there's an event, that they're concerned, they're dizzy, they're lightheaded, whatever it is. We assess immediately, gauge the level of response that the patient's needed, and then we have agreements with the local rapid response vendors to appropriately provide the right care at that time. So this is how we put together that amazing journey that Vivian described a little bit. So now that I've shared with you some of the equipment that supports our patients in our program, let me now share our target patient population and some examples of patients we've already enrolled. So the type of care that we can currently provide in our program. We provide 24/7 virtual and in-person care. It's a combination of advanced practitioners, nurses, and physicians to pull this off. Now we do IV therapy such as Lasix for diuresis, or antibiotics in the IV form because the oral antibiotics didn't work, or IV fluids because that's simply what the patient needs as a balance when you're diuresing too much. We're able to do nebulizers at the home. So someone that has COPD or asthma and they need albuterol and such medications and nebulizers, we're able to do that. We're able to provide oxygen and other DME in the house for the patient in order to make sure that it aligns with the treatment plan. Wound care is something that we're able to do. Amazingly, we're able to pull off x-rays and ultrasounds at the house. And what I found incredible value is because as a physician, I like to compare my x-rays one to the other. And the way that we've done this is that we are able to look at patients' prior x-rays and compare them to make it apples to apples. We're able to do daily labs in order to make responses needed. When you manage someone's electrolytes, you need to adjust it all the time. And when you're diuresing them, that tends to be one of the things that you have to do. You need labs to do it. But what's unique about our program is that not necessarily do we do daily labs because it's just what you do, and that's what happens in the hospital setting. We only do it if we need to. Because when you poke somebody for a lab, it means a lot. You got to wake them up. You got to call, have somebody coordinate the pickup and the draw, and make sure the lab results are in a timely fashion for the providers to see and act upon. Now, that makes physicians think a lot more about what is needed and when it's needed. So it's kind of interesting as a way that we're more prudent about the type of care that we provide, and it's patient-centered the entire time. Now, I've told you in terms of what we're capable of doing, but some of the things that we also are aware of is that we need to make sure the acuity of the patient is appropriate for the home care. So for instance, the clinical trend of the patient needs to be appropriate. They have to be stable or improving, and they have to have a clear diagnosis. So this is where we request and require a soft handoff between the brick and mortar physician and our virtual hub physician to make sure there isn't something that's not captured by the chart that makes the home not a conducive environment for recovery. And then beyond that, we go and address the social determinants of care. Folks that are here at HIMSS know the social determinants of care make up just as much of medical care as it does in just healthcare in itself. So no social factors that would jeopardize care in the home. There's something that we can see and we can kind of be ahead of. So homelessness or unsafe home setting, no running water, heat, electricity, active substance abuse, uncontrolled psychiatric illnesses. These things not only are not conducive for the patient, but they're not safe for our clinical team that's trying to be in the patient's house to provide care. And one thing on here that I'm the most impressed by, and I feel that it just speaks to the type of care that we provide, is that patients consent to the care at home. We have had multiple focus groups in order to make sure that we are taking and using the right direction to be able to provide this wonderful care. And one of the things that keeps coming up is that patients just need to understand. And when someone understands the program and consents to it, not only do you have buy-in, but you have significant compliance and trust when you need it the most. So now let me share with you some of the diagnoses. Like, we talked a lot about the type of patients, but some of the patients that I've actually had the pleasure of taking care of in my program. CHF. Now, folks that are not clinical, I know that there are folks here that are not clinical. And so CHF is a diagnosis that we see that makes an impact on our healthcare industry, because a lot of patients that are admitted in the hospital setting for CHF and discharged tend to come back, a significant percentage more than other DRGs. So taking on this DRG means something, because it means we're going to disimpact our ED and not impact our hospitals as much. And what we're already seeing is with the scales and really having that honest conversation about fluid intake and what you're trying to do at home, we are making an impact on heart failure patients. Cellulitis is a perfect example of what Vivian explained, of a patient who did regular antibiotics, didn't work, and the IV antibiotics made a difference. And simply because there's no other way to get that IV antibiotics to be in a hospital environment to have daily labs, our program stands out. These patients do wonderful in our program. They actually are more functional in our program because they're active otherwise, except for the small infection. COVID pneumonia is one that we really did make an impact this past year. I've already shared with you a little bit of how we took on medications that typically happen only in the hospital setting, but we also took on therapies that happen in the hospital setting and incorporated in the home environment to make it safe and make the patient understand why it works well for them. UTI pyelonephritis is one of my favorite stories. I had the most unbelievable privilege of taking care of a wonderful lady who just shortly after delivering a baby during the pandemic ended up getting a bladder and a kidney infection. So 2 days after delivering, she had to come back to the hospital, to the ED, diagnosed with this infection and told you have two decisions to make. One, you got to be admitted in the hospital, so that way you can get IV antibiotics, and your baby has to come, feeding in between intermittently in order to be able to get feedings, but otherwise the baby can't come in the hospital because we had visitor restrictions during COVID pandemic. Well, the other option is we can try to take a trial of oral antibiotics and see how it goes at home, but if it doesn't work, you're gonna have to come back right away anyway. Well, that's when our program was introduced to this patient. And wonderfully, she had this unique opportunity to spend time with the baby at home, do the maternal bonding that was important, receive the IV antibiotics that allowed her kidney infection to be resolved, and still not compromise her health care. It was incredible. And I took care of this case, and watching her and watching the babies there, it was actually pretty incredible. And one of the last things on my last day on the visit was when the husband got on the video and actually said, I just want to thank you for making it more reasonable for me, because everyone's talking about my wife, but I just want to let you know as a dad what this program did for us. So I just want to share with you some incredible stories that we're creating with our patients. And the last thing I want to point out is what's unique about our program is that we're able to do dual diagnoses. So it's not just the heart failure patient that we spoke about or the cellulitis patient that we spoke about, but it is actually a patient that has heart failure with kidney dysfunction and is also a diabetic on insulin that we need to manage. And this type of complicated dual diagnoses, to be able to do it in the home environment, to know what they're really like and what they're eating in the fridge, what they're taking care of, that is how we make incredible impacts for these patients. So now that I shared with you some of the incredible stories and stories here at this time in terms of our patients, I hope they enjoyed some of the cases that we've shared. But without any further delay, I'd like to actually pass the platform to Chris to hear a patient's voice at this point. Thank you very much.
Mr. Jolly is a gentleman with acute kidney injury. Monitoring is very important with these patients. Usually hospital stays on this are at least 3 to 5 days, sometimes longer, depending on the kidney function. He was 48 hours into his hospital stay, and he was feeling quite fine. He asked, is there any other way to do this? We said, guess what? We have a way. We have our Advanced Care at Home program opening up. Advanced Care at Home is taking what we do in the inpatient setting and transforming that and bringing the care to the patient in their home. We're able to transport, with Mayo Clinic, transport the patient out of the hospital setting into their home environment. We meet them with an APP and a tech pack. The tech pack contains everything we need to take care of that patient over the acute phase of care. That includes connected, secure, HIPAA-compliant Wi-Fi, monitoring for blood pressure, pulse ox, a scale, any other medical supplies they need, along with the tablet that provides the virtual connection to us, as well as a daily schedule so the patient knows exactly what's happening from time to time. We set that all up in the house and connect it, we test it. Our hands on the ground EMS or APP staff does a physical exam, make sure the transfer was safe. I connect in, talk to the patient, make sure that he's doing well. And that's what we did for Mr. Jolly.
Keeping your fluids up as you're doing is important. And if the number gets a little worse, that just means we need to give you more fluid. That would be a result.
You're monitored as if you're in a hospital. For example, they actually see you take the medicine and they can verify it. I think the best part of it is during the day, they've taught me how to do my blood pressure and oxygen in the blood and stuff like that. So I get my own vitals and send it to them. But also, if it's important enough, where I know that with the thing is 24 hours a day, all I have to do is push a button and there's a picture of a nice young lady and I can start asking her questions at 2 o'clock in the morning or 3 o'clock in the morning.
Plus your mobility is much better too.
Yeah, I think that was the worst thing about being in a hospital. I could not get up out of the bed and take a walk. I just love the idea that I can read and then I can get out and look at my marsh view. It's just so much better to be home.
We have the resources now to treat our patients better, to give them equal, if not better care, to provide better satisfaction in their home environment, and to reduce costs to our patient and ourselves. It's the next evolution of medicine, and we should all be part of this and striving for this and what's after this.
I think the big thing about this is the word I would say is it gives me, a patient, freedom.
So Mr. Jolly's story is just one example of the hundreds of patients who we have cared for within our Advanced Care at Home program. And just as a quick side note, Mayo Clinic has provided care for more than 973 patients since we launched our program. And as you can clearly see through the video, there are tremendous benefits offered through the Advanced Care at Home program. But one benefit that seems to stand out above the rest, and I mean, you can clearly see it and feel it within this video, is the patient experience. And not just the patient, but the patient's family and the respective support system. So I'd like to take a quick moment, if we can advance the next slide, perfect. So I'd like to take a quick moment just to clarify something, because I believe the title of this panel could generate a bit of confusion. I personally do not see a future where hospital at home completely replaces the brick and mortar hospitals in today's healthcare landscape, nor do I see it fully replaces the hospitals that we are constructing in the future and planning for. I wholeheartedly believe that the Advanced Care at Home programs are a complement to the hospital of the future. So excluding hospital at home capabilities from your future hospital design and operational workflows, to me, I would view that as a failure and short-sighted. Now, I know that seems maybe a little harsh, but I truly believe that patient experience will demand this functionality. And we are here to serve the needs of our patients. So that demand is going to become the reality for our providers and for our organizations. So through the lens of why, what, and how, I'd like to just quickly highlight how our Advanced Care at Home program elevates and complements the strategy centering on hospital of the future. So why do Advanced Care at Home? Taking the viewpoints from external stakeholders. For the patient, it is highly personalized, on demand, and a digital experience. For the payer and employer, it is cost control. For the IT sectors, it's positive digital disruptors via artificial intelligence, cloud technology, platform mechanisms, cutting edge devices, and much more. We pivot to the viewpoint from Mayo Clinic and internal stakeholders. It's value. We innovate to drive quality and affordability for our patients. It's sustainability. We diversify revenue streams to alleviate production pressure. And it's brand. We're continuously reinforcing our commitment to excellence and proving to be here for our patients in any time of need. The what is that advanced care at home will deliver the necessary services, technology, and capabilities to safely shift hospital level care to the patient's home, just as you saw with Mr. Jolly. So how do we accomplish this? There's 4 key components that I want to highlight. Clinical expertise. As Dr. Reyes and Dr. Venkat shared for you earlier on this panel, it's driving that effective care model for all of our patients. It's a technology platform through technology-enabled care and sort of a air traffic control maneuvering. It's logistics expertise for a highly reliable in-home ecosystem for our patients. And it's payer solutions through partnerships to present new payment models. So this slide highlights 5 key themes that I want to touch on from our our advanced care at home programs, and justify why hospital at home should be included in hospital of future planning efforts across every organization. The first, increased safety for medication identification and administration. The second component, leveraging AI and proactive analytics to elevate patient care, regardless of what the diagnosis is. Growth and opportunities to introduce more service lines based on patient demand. As you saw, Dr. Venkat's component, there's different diagnoses that have continuously been introduced as these programs continue to mature and grow, and our clinical expertise gets used and comfortable with the types of patients we can safely care for. Timely admissions from various locations, whether it's the hospital unit, whether it's the emergency department, urgent care, and more. Those are key components of this program. And then quicker coordination of supply chain dynamics to the patient's home. But going back to my previous comment, and whether you agree with it or not, planning for future hospital capacity and optimal bed management should incorporate hospital at home or advanced care at home, some type of in-home care program. And at Mayo Clinic, specifically for our destination medical center sites in Florida and Arizona, we anticipate that the advanced care at home program will grow to provide eventually 10 to 20% of our inpatient care for our current hospital census. That will ultimately allow us to grow our access for more complex care, whether it's the neurosurgery components, ECMO, CAR T therapy, transplant, you name it. So so what does this mean for all of you? How does this work? How does it tie back to you as healthcare leaders, IT leaders? And while you might not have anticipated that there was going to be a call to action within this panel, we and many other hospital at home programs need your support. As illustrated on this slide, there's a few critical topics that we want to highlight before wrapping up this panel session and looking forward to the Q&A component here for everyone. So the first is there's challenges that exist between interfacing the electronic health record to other operating systems. Again, for us within the Medically Home program, we leverage SEISHA, which is a different program than the EHR that our clinical staff are used to. So there's additional training that needs to go into place. And many of you know, working in a healthcare system, you have clinical informatics that are tailored and programmed to a specific EHR or specific types of modules. This introduced a new dynamic to our staff. And so it did require training and interfacing. So we're hoping that we can continue to enhance and build on that platform to get to a higher level of user friendliness to support our teams that are providing this great care. Second component is the supplier network depends on strong partnerships with key vendors across a wide spectrum. So again, the example for our radiology diagnostics. So transmitting studies from vendor mobile diagnostic products into the EHR, that compatibility is going to be really important to make sure that we're delivering timely care to the patients in their home setting. Another component, as you can imagine, is HIPAA compliant communications, because we are now spanning a pretty wide spectrum of caring for the patient in different environments. So we have to be able to have that secure chat, that secure communication outside of the brick and mortar, and make sure that we're not compromising or putting the patient's data or privacy in risk as we're delivering this care. The fourth, continuously enhancing and accelerating the efficiencies of the supply chain network is going to be really important. that piece makes or breaks some of the models. So that partnerships and how you're collaborating with whether it's home health agencies in your community or in-home rehab facilities, phlebotomy, all those components are going to be required to deliver a faster, more efficient supply chain and a better experience for the patient. And the last part that we won't spend too much time on, but there's an evolving regulatory environment centering on hospital at home. Again, the public health emergency that's been extended, this hospital at home care for the CMS patients was tied directly to that public health emergency. So there's been great groups, several or a couple coalitions that have been lobbying and really advocating for this program to kind of untether itself from that public health emergency and realize that this is truly inpatient care of the future and a great opportunity and a great way to expand how we care for patients. So other things that hit the regulatory framework, again, the scope of what paramedics can and cannot do under physician or advanced practice provider direction, pharmacy operations, there's a whole slew of things. So there's many ways to advocate and support hospital at home advancements. Again, the coalition, Kaiser Permanente and Mayo Clinic are a part of the Advanced Care at Home Coalition. We've been very active in that regard. And so there's a lot of opportunity to get engaged and continuously promote this. And well, I don't hope this on anyone, but if you or a family member or a loved one or a friend have to go through hospital at home, sharing your experiences with that team is a great way that we get better. So we're very intentional about capturing the patient experience, the family's experience, because we want to deliver an unparalleled experience for them in this model. So a lot of opportunity there. So in closing, I know we have a couple minutes here, but on behalf of Dr. Reyes, Dr. Venkat, myself, we want to thank you all for listening to our perspectives, our advocacy for advanced care at home. You can clearly see that we are biased. We've really enjoyed the benefits of this program. I'll share for us at Mayo Clinic and specifically in Florida, this program was tremendously important as we were going through the COVID-19 surges and really trying to understand how we can balance that hospital capacity, continue to provide tertiary complex care for our patients. So again, so at this point, we'll pivot the panel program, take down the slides, and I think I'm tasked with going through our Q&A function here. So I will do my best to serve as the moderator here and not goof anything up. But just a reminder to everyone in the audience, if you have a question, please go ahead and enter it in, or if there's a question that's already posted that you really agree with, give it the thumbs up or the like symbol on there. And I think we're going to go ahead and take a couple shots at some questions here. So first question, I see that had a couple of thumbs up here. It's from Judy. And the question is, does insurance limit the number of hospital at home visits that are covered and that a patient can receive? So Dr. Reyes, Dr. Venkat, do you want to take a first shot at this?
Sure. So the answer is yes. So hospital at home in general, the environment around it is moving. So prior to the public health emergency, it was not recognized as a thing, meaning that you couldn't actually bill for it. So the public health emergency came on, there came in some sort of regulatory structure around it, so they were recognized. And so the way that insurance can cover for it now is different depending on how your program is set up. So for example, if you are set up as a home health type program, the insurance will cover parts of it depending on how you set it up as a program. Other places you need to actually get a supplemental benefit so that services covered under the program are covered. People who are under the waiver will have different ways that they can get reimbursement. And so it really comes down to how is your program structured, and then what types of benefits do you have to cover that? And so it's a really messy question and it's moving. So we keep saying that we're building the plane as we fly it. And that's exactly my sentiment around this question. But yes, insurance does limit who we can take to the program and in what areas, because it depends on coverage really is, it changes depending on the area in which the patient lives. So I'll stop there and see if Dr. Venkat and Chris want to add on to that.
I think you covered it. I mean, it's specific. It gets back to kind of my comments earlier that it really is about those partnerships. We've had several great meetings with different payers and different groups who understand the value and the importance of patient experience and how this model can help with controlling costs. But having said that, I think we're still in the early phases of this journey and in society accepting this model of care. There's certainly still some anxiety, a patient who's maybe first hearing about this and then all of a sudden going into it. So again, I think in time we will continue to see this gain momentum. And that's where it's really important for early adopters of this, again, to be seeking feedback from the patients, from the payers, publishing on the research, making sure that this is an evidence-based driven program, that we're not seeing higher readmission rates or adverse events, additional falls. So all of those things kind of really funnel into that answer.
And I'll just add one other thing, Chris. I really think that it's the reimbursement has been the barrier. So if you just looked at this program, the outcomes, the patient experience, no question that it is safer, it's better care, but reimbursement has really been the barrier to programs really scaling, because you need reimbursement to keep your programs growing. So I think once we get there, I think you'll see these programs really start to grow.
Dr. Venkat, any last comments you'd add? Last word on that question before we move on?
No, I think you guys covered that really well. I mean, for the most part, we as an operational model, we try to do the right thing for the patient every time. And so if we need to, we learn from it. And then we ideally operationally see where we can work with our sponsors and work with our folks to make sure that the patients receive the utmost, the best care possible.
All right. So our next question, more clinical in nature, so I'll look to our physicians maybe to answer this one, but insulin sliding scale administers 4 times a day. Does the program have nurses go to the home 3 to 4 times a day to check glucose, administer insulin? How does this work for the hospital at home program?
It's a great question, by the way, and Chris, I can take that one right off the bat. So, and let's just not talk just about insulin. Let's talk about even any medications that need to be administered at home every 8 hours or 6 hours. So there is a component to where we want to make sure that we can provide the right type of therapy appropriately for the patient. So when we first start, and for instance, take somebody that's diabetic and is insulin dependent, they're probably 3 times a day that we need to be there. Someone as a nurse is in the house teaching the patient how to load the insulin, doing it. And then after a certain period of time, they actually graduate to a point where we feel comfortable and we watch them do it. And then they actually ultimately do this on their own. So we watch them as they go through it. So insulin is just one example of that, of how we do it. But our goal is to ultimately be something where it's something that the patient is able to do this on their own eventually, right? As if like they were discharged from the hospital, how would they take care of the insulin at that time? We want to kind of test that water and get them to it. But can we provide it 3 times a day? We absolutely can. Do we have nurses go to the house 3 times a day? We can, but we prefer not to be that intense right away. And maybe that's not the type of patient that's ideal if they're getting insulin 4 times a day, getting antibiotics 4 or 5 times a day on top of that, multiple things. This is where the clinical screen and the acuity that we look at as a soft handoff between the physicians to make sure, can we meet what the patient needs from a treatment plan safely and appropriately? So we can do it, but our goal is to transition slowly to something that makes sense for the long term for the patient as well.
And I would just add to that, I talked about the restorative phase being the secret sauce to this program. In the old days, we used to always rely on family, caretakers, friends to care for patients. And in other countries, you still see that. In the United States, in brick and mortar, we've really gotten away from that. And in fact, we don't want visitors to touch the patients in the hospital. But then they go home and suddenly, who's supposed to take care of these patients is their family and their friends and their caretakers. And so, with this program, it really engages the patient, their caretakers or friends, family, to really be part of the patient's care. And I actually think it adds to that holistic provision of care. So I think that's sort of the goal of the program, and that's how the restorative phase really plays in as well.
Vivian, you hit that spot. I got to tell you, just to add on a little bit more, there's many times where I've seen the caregiver involved, the relationship becomes stronger because of our program. And initially they were hesitant to be involved with insulin or wound care or whatnot. And then as you grow together as a team, because we create that relationship, and it's really thick. And at that time, it's a bond. When we discharge somebody, you really feel it. And that patient and the caregiver, they express that to you. So this is that caregiver and patient empowerment. It's all together wrapped up there.
Yeah. I'd echo the comments. And I think, as Dr. Venkat, as you even commented, it's a privilege for us to get to go into the patient's home and provide this care, but we learn a lot. And I think, we could all maybe relate to a hospital experience where when you're getting ready to be discharged, there's a lot of information that the care team is throwing at you. And so having that environment, we've seen many examples where the patient's family member support system's they're involved. They've, gotten practice with measuring certain things and helping holding the patient accountable. So it really has been a great program to see continue to grow and evolve from that stance. So our next question is how do you perform the imaging at home? What type of technologies is available at home for medical imaging?
So the two, I can take this one. We have two supply chain partners that we work with in Napa Solano area. Mobile imaging is one of them, and they do x-rays and ultrasounds at home. This was technology that exists. Really what we've been working on is in the background, making sure that those images are safely and HIPAA compliantly transmitted to our digital librarian in order for our radiologists to read and compare for future images as well. So this is a lot of, the hardware is one set, and then there is a software component of it that you have to have the right partners that hopefully are aligned with your EHR in terms of the software to be able to make it easy transition. Now I'll tell you, those two things are working pretty well. Our EKG is another story, and we're working to be able to, fix that component in order to make sure that it's more seamless that you want to. But those are the current opportunities there. I will tell you that it's kind of cool. There's some really amazing things that people are doing out there. There is a particular portable CAT scan that's out there. We do not utilize it in advanced care at home. I'm just kind of throwing it out there for hospital home and tech folks that are interested. But it's essentially a portable CAT scan. It's looks like the size of a mobile home, but it can go anywhere and do CAT scans at any given location for a patient to be transmitted. So there's a lot of really exciting stuff that's coming in this way, but we're only using x-rays and ultrasounds at this time.
All right, our next question is, was there a requirement for a household patient advocate, i.e. a guardian, to assist the patient, especially those that may be digitally challenged? It's a nice way to word it.
I'll start, and then the other two can chime in. So no, there is no requirement that there is another person in the home. So we have treated patients who live on their own and do not have a caregiver. I have not. Dr. Venkat could probably answer more about the digitally challenged, but what I will say is that we have gone to great lengths to make the technology really easy to use. My mother is 85 and very digitally challenged, but I am confident she could use the technology we use. It's very easy, and it doesn't take a lot for folks to interface with it. So Dr. Venkat, I don't know if you want to talk more in detail about that digital part.
I took care of a centenarian. It's like that's on a bucket list of mine somewhere, I'm sure, back in medical school, but I took care of a 100-year-old female in our program. And the advances that she's seen in technology, it was pretty incredible in terms of what we were able to do. The variety of patients that we take on in terms of what they do from a technology standpoint, whether they're used to it or not, when they leave our program, they're just more comfortable. And within KP, we really believe in acclimating patients to their home environment and their virtual environment. And a lot of our physicians practice in a virtual environment. So we're hoping that we can be that transition sometimes and help people get more comfortable with it. But even earlier today, Vivian and I were on a call where we had a patient share his story, and he flat out says, I'm not a technology guy, but this makes a lot of sense. And this is the future of medicine. I can see it. And it's the same story that I hear from retired principals and teachers and crossing guards that are just all over the place, but totally get our program and are able to put on that heart rate monitor when I need them to, get on the scale when I need them to, check a glucose and give me the input that when I need them to. So it's been working really well.
Next question is, how has the pandemic impacted the ability to scale the services to home with local partners, i.e. the supply chain? How geographically spread out are the 973 patients who have been treated by the program? Question for Mayo. So I will take this one. So for us, right now we're functioning with a geographic region of 30 miles, really a 30-minute drive to the hospital. And that's in the event that a patient's health starts to decline, that we can quickly get them in through the ED and get them the services, see if they need to be admitted to our brick and mortar hospital or if they can return home